All right, let's get into it. Today, we're going to master surgical calcium disorders. This is an absolutely crucial topic for your board exams, so let's think like safe surgeons together and really get this down cold.
So, here's our plan of attack. We'll start with the basics of calcium. Then we'll dive deep into hypocalcemia, how to spot it, how to manage it. After that, we're going to pivot to hypercalcemia, and then at the end, we'll wrap it all up with a master algorithm and some super high-yield pearls. Think of it as our pre-op briefing before we scrub in.
Okay, first things first. Before we can even think about fixing calcium problems, we have to understand how it actually works in the body. This stuff is the foundation for every single decision we're going to make down the line. Now, check this out. It's really interesting. Only about half of the calcium floating around in your blood is actually doing anything. That's the ionized or active form. The rest is just kind of hitching a ride, mostly stuck to albumin. This is a huge deal, especially in the ICU where patients have low albumin all the time. You just can't trust the total calcium number. You've either got to check an ionized level directly or you do the correction. For every point the albumin is below 4, you add 0.8 to the total calcium.
And this right here is exactly why that ionized number is king. It's the only fraction that actually matters for nerve firing, muscle squeezing, and blood clotting. And who's the main regulator of all this? Parathyroid hormone, or PTH. It's got 3 main targets. It tells the bones to release calcium, the kidneys to hold on to it, and the gut through vitamin D to absorb more of it.
So here's a crucial point you got to understand. When your blood pH starts to climb, becomes more alkaline, more of that active ionized calcium gets gobbled up by albumin. So what happens? The active level tanks, and you start getting symptoms like muscle spasms, even if the lab report for total calcium comes back perfectly normal.
Okay, surgeons, pop quiz. This is a classic board question. You've got an anxious patient, they start hyperventilating, and suddenly their hands are cramping up. You draw a total calcium and it's normal. So what's going on? You know this one. The hyperventilation blew off CO2, causing a respiratory alkalosis, and that dropped their active ionized calcium.
All right, let's move on to our first major challenge. Let's see how this all builds, because you have got to be able to spot low calcium before it turns into a total disaster.
So the big red flag for hypocalcemia is neuromuscular irritability. Basically, the nerves get twitchy. It usually starts with some tingling around the mouth. Then it can progress to cramping in the hands and feet. We call that carpopedal spasm. If it gets really bad, you can even get airway spasms or laryngeus stridor, and even seizures. And on an EKG, you've got to look out for a prolonged QT interval, because that's a setup for some really nasty heart rhythms.
You absolutely have to know these 2 physical exam signs cold. Chavostex is when you tap on the facial nerve and the face twitches. Trousseau's is when you pump up a blood pressure cuff and it makes their hand cramp up into that classic spasm. For your exams, just remember, Trousseau's is the much more specific and reliable sign.
Now, picture this. You just finished a big parathyroidectomy. You're on high alert for hypocalcemia. But you've got to figure out why it's happening. Is it because the parathyroid glands are stunned or gone? Or is it this thing called hungry bone syndrome, where the skeleton is basically a giant sponge sucking up all the calcium? Just look at the PTH and phosphate levels here. They move in opposite directions. That's your key. That's how you tell them apart. Okay, quick. You're in the recovery room. Your patient's calcium is dropping, but their PTH is going up like it should, and their phosphate is low. What's the diagnosis? You got it. It's hungry bone syndrome.
Okay, so now we know how to spot it. Let's talk about the right way to fix it, because trust me, you don't want to get this wrong.
Listen up, because this is a pearl you cannot forget. Magnesium is the master key here. Your body needs it to secrete PTH, and it needs it for PTH to even work. So if your patient's magnesium is in the toilet, their calcium will never get better, no matter how many bags of calcium you hang. You always check and fix the magnesium first.
So which IV calcium do you grab? Well, it matters. For pretty much most situations, if you have a peripheral IV, you want calcium gluconate. It's a lot easier on the veins. But if you're in a code situation, or if you have a nice central line, then calcium chloride is the move. Why? Because it delivers 3 times more active calcium.
All right, high yield alert. Let's burn these common board traps into our brains so you don't fall for them. First, we've already hammered this home, but never ever forget magnesium. Second, in the ICU, always check an ionized calcium.
Third, with pancreatitis, don't just automatically replace low calcium unless the patient is symptomatic, because you can actually make things worse. And last, never ever mix IV ceftriaxone and calcium in the same IV line. They can literally form little rocks. Deadly.
Okay, let's flip the script. Now we're going to tackle the opposite problem. Too much calcium. Just remember that classic saying for the symptoms? Painful bones, renal stones, abdominal groans, and psychic moans.
The entire workup for high calcium, everything you do next, comes down to one single lab test. This is what I call the PTH pivot. Your entire diagnostic pathway is determined by this one result.
And this is it. This is the whole concept. If the PTH is high or even just inappropriately normal, the problem is with the parathyroid gland itself, usually a little adenoma. But if the PTH is low, like it should be, then you got to go hunting for another cause, and the most common culprit is cancer. So you see, this one lab sends you down two completely different roads.
Okay, so let's say your PTH comes back high. You're not done yet. You have one more critical step, and that's telling the difference between primary hyperparathyroidism and a benign genetic condition called FHH. And the key test for that is the urine calcium to creatinine clearance ratio. In FHH, the kidneys are just holding on to way too much calcium, so that ratio is going to be super low, less than 0.01.
I want you to hear this loud and clear. You will see this on your exam. Taking a patient with FHH to the operating room for a parathyroidectomy is a major, major error. It's a completely unnecessary operation, and it won't even fix their calcium levels.
Okay, let's talk about managing a hypercalcemic crisis. This is a true medical emergency, and the order in which you do things is everything.
This sequence is absolutely non-negotiable. Step 1, always, is aggressive IV saline. You have to remember, these patients are incredibly dehydrated. Calcitonin works fast, but it stops working after a couple of days. Bisphosphonates are your long-term solution, but they take a few days to kick in. And look where furosemide is, way down at the end. Giving Lasix before you've tanked the patient up with fluids is a classic board killer question. You'll just make them even more dehydrated and make everything worse.
All right, let's put it all together. This is your master plan. This is the mental flow chart you're going to use on exam day and out on the wards. This right here is your takeaway. It's your cheat sheet. For low calcium, what's your first step? Check an ionized level. What's the key branch point? The magnesium level. For high calcium, first step, check a PTH. Key branch point. Is that PTH high or low? The treatments just flow logically from there. Just remember, safe surgeons don't just memorize answers, they have a system to prevent disasters. And now, you've got one too.